our webinar on vaccines in pregnancy. My name is Dr. Eimear. I am a Senior Medical Officer in the National Immunisation Office. I will just introduce you to some of the other people on the panel. So we have Dr. Eogan, who is a consultant in public health medicine. We have Cría Dowling, who is a communications officer here in the National Immunisation Office. And on the chat box today, we have Dr. Alice Quinn and Dr. Tom Barrett, who are both senior medical officers in the National Immunisation Office as well. If you have any questions throughout the presentation, you can put them in the chat box and they'll try and answer as many questions as they can. So on the agenda today, I'm going to go through the recommendations on vaccination during pregnancy and before and after pregnancy. And then we have two recordings that the first one, Professor Maeve Eogan from Rotunda Hospital has kindly provided us a recording on vaccines and pregnancy. And Dr. Geraldine Casey from the HPSC has provided us a recording on vaccine-preventable diseases and pregnancy. And then Cría is going to speak a little bit about available resources for vaccinators. And then I'm going to speak about some frequently asked questions that come to our office from clinicians and a little bit about COVID-19 vaccines and some questions and answers that pregnant and breastfeeding women may have about them. And then we'll finish up the meeting. So to begin with vaccines and pregnancy, the National Immunisation Advisory Committee provides the immunisation guidelines for Ireland based on the latest clinical and scientific information. NIO recommends some vaccinations during pregnancy to protect the health of the mother and their baby. Live attenuated viral vaccines are contraindicated in pregnant women. These are vaccines such as the MMR vaccine, the varicella vaccine, and the live attenuated influenza or nasal flu vaccine. With these vaccines, there is the theoretical risk of harm to the fetus if the vaccine virus should replicate. And if someone receives one of these vaccines, they should avoid pregnancy for 1 month after vaccination. Non-live vaccines cannot replicate and cannot cause infection in either the mother or the fetus. No scientific evidence exists of fetal risks from vaccinating pregnant women with non-live vaccines, and they're generally considered safe in pregnancy. So vaccines recommended during pregnancy are the pertussis or whooping cough in the Tdap vaccine, the seasonal influenza flu vaccine, and the COVID-19 vaccine. Vaccines recommended before pregnancy are the MMR vaccine. As I said before, pregnancy should be avoided for 1 month following vaccination. And then vaccines to consider after pregnancy would be the Tdap vaccine if they weren't vaccinated during pregnancy, and the MMR vaccine. So vaccines recommended during pregnancy. The whooping cough or pertussis vaccine. Pertussis or whooping cough is highly infectious. Infants under the age of 6 months are most at risk of complications and hospitalization, and they're too young to be fully vaccinated. Pertussis in hospitalized infants, 50% have apnea, 20% have pneumonia, 3% have seizures, and 1 to 4% sadly may die. The pertussis vaccine or the Tdap is recommended for pregnant women to both protect the mother from infection, but also to provide protection to newborn infants through antibodies from their mother. The National Immunisation Advisory Committee recommends that all pregnant women should be offered the Tdap vaccine as early as possible after 16 weeks and up to 36 weeks gestation in every pregnancy. If a woman was not vaccinated during their pregnancy, the Tdap should be offered in the week after delivery to protect the mother from catching pertussis and passing it to the baby. The Tdap vaccine is free during pregnancy. In November 2018, a national outbreak of pertussis was declared. Your local Department of Public Health should be able to provide you with an outbreak code to claim for the administration of Tdap vaccine for pregnant women from 16 weeks in pregnancy. This means that the vaccine and its administration are free for all pregnant women. The flu vaccine. Pregnancy increases the risk of complications from influenza because of alterations in heart rate, lung capacity, and immunological function. Influenza in pregnancy is associated with miscarriage, premature birth, and stillbirth. Vaccination during pregnancy provides protection to the mother and provides passive immunity to infants up to the first 6 months of life. Infants under the age of 6 months are too young to receive the influenza vaccine and have the highest rates of hospitalization and death from influenza. NIO recommend the flu vaccine for all pregnant adolescents and adults at any stage of pregnancy each flu season. Pregnant women are advised to have the QIV flu vaccine. The QIV is an inactivated influenza vaccine. It is not a live vaccine and is considered safe in pregnancy. The COVID-19 vaccine. Pregnant women are at similar risk of COVID-19 infection to non-pregnant women. However, pregnant women and adolescents with COVID-19 infection are at higher risk of severe illness compared with non-pregnant women, especially in the third trimester. Pregnant women who get COVID-19 are more likely than non-pregnant women to be admitted to hospital, to require care in an intensive care unit, and to die from COVID-19. In Ireland, between March 2020 and August 2021, of the pregnant women admitted to ICU with severe COVID-19, none had been vaccinated. COVID-19 infection in the mother may result in preterm delivery. So the recommendations on COVID-19 vaccines in pregnancy. mRNA COVID-19 vaccination is recommended during pregnancy unless there is a contraindication. For unvaccinated pregnant women, the primary COVID-19 vaccine schedule may be given at any stage in pregnancy, and the recommended interval can be found in Table 5A1 of the Immunisation guidelines, and this is dependent on their age and immune status. A COVID-19 booster vaccine is recommended once in pregnancy. If a pregnant person has not had a previous COVID-19 booster, the first booster dose is recommended at least 4 months after their last COVID-19 vaccine dose or SARS-CoV-2 infection. For pregnant women who have had a booster dose prior to pregnancy, they should receive a booster dose once in pregnancy at an interval of 6 months or more since their last booster dose or SARS-CoV-2 infection. Booster doses can be given at any stage in pregnancy, but ideally should be given between 20 and 34 weeks. If it is more than 12 months since their previous COVID-19 vaccine or infection, administration earlier than 20 weeks in pregnancy should be considered. For those who are pregnant and are immunocompromised, a second booster dose within the same pregnancy may be considered if 6 months has elapsed since their last booster dose or SARS-CoV-2 infection. It's important to mention that these are the current guidelines on COVID-19 vaccines and pregnancy. They may change, so it's best to always check what are the latest guidelines, and they can be found on the RCPI website, the immunisation guidelines. Vaccines recommended before and after pregnancy. So, as I mentioned, vaccines recommended to consider before pregnancy would be the MMR vaccine, and after pregnancy would be the pertussis or whooping cough Tdap vaccine. If they were not vaccinated with Tdap during the pregnancy, Tdap should be offered in the week after delivery, and MMR vaccine could be considered after pregnancy if they haven't been vaccinated before. So just a little bit about the MMR vaccine. Before getting pregnant, a woman should ensure that she is immune to infection from rubella or German measles. Rubella infection during pregnancy may cause miscarriage or stillbirth. Up to 9 out of 10 babies can have major birth defects such as deafness, blindness, brain damage, or heart disease. This is known as congenital rubella syndrome. The MMR vaccine provides immunity to infection from rubella. The MMR vaccine given before pregnancy provides protection against rubella infection in any future pregnancy. Documentation of having received at least 1 dose of a rubella-containing vaccine is satisfactory evidence of protection against rubella, irrespective of serology. MMR vaccination is only required if there is no documentation of the woman having had at least 1 MMR vaccine in the past. And again, just to note that the MMR is a live vaccine and pregnancy must be avoided for 1 month following vaccination. Okay, so now I'm going to play a video that Professor Maeve Eogan from the Rotunda Hospital has recorded for us. Sorry, I don't think there was any sound there. Just give me a second.
Questions people may not available for this webinar in person, but my contact details are there on the first slide, and I'm very happy to address any questions people may have after the event. So the title today is focusing on "This choice does not just affect me," and the impact of vaccination on pregnant women. I have just affect me, and the impact of vaccination on pregnant women. I have no financial relationships with any relevant commercial interests, but I would like to acknowledge my research and clinical collaborators, particularly Dr. Sarah Geoghegan from Temple Street University Hospital. We all know that vaccination against infectious diseases is an intervention with a very significant impact in public health over the course of the history of medicine. And the rationale for vaccination in pregnancy is that there's active transplacental transfer of maternal antibody across the placenta, which then causes passive protection from this maternal antibody for the baby in the first few months of life, and until the child's own antibodies kick in after they've been vaccinated in the postnatal period. But in addition, of course, vaccination in pregnancy has very real benefits for the mother. And we saw that particularly in the context of both flu and COVID-19 pandemics in the past. Eimear has already spoken to you on the recommendations for vaccination in pregnancy, but you'll be aware of these. It's recommended that people are vaccinated for influenza at any time in pregnancy once they're pregnant during the flu season, for pertussis from 16 weeks gestation, and COVID-19 booster from 20 weeks gestation if they haven't had a recent COVID-19 infection or if they haven't had a recent booster. And the other vaccines which may come down the track include vaccination for Group B strep, which is carried by 20% of the population, and indeed vaccination antenatally for RSV, respiratory syncytial virus, to protect babies from this virus.
Sorry about that. Just give me 1 second.
Hello, my name is Maeve season for pertussis from 16 weeks gestation and COVID-19 booster from 20 weeks gestation if they haven't had a recent COVID-19 infection or if they haven't had a recent booster. And the other vaccines which may come down the track include vaccination for Group B strep, which is carried by 20% of the population, and indeed vaccination antenatally for RSV, respiratory syncytial virus, to protect babies from this virus early in the postnatal period, where it causes a significant risk of hospitalization and ill health. And RSV vaccination indeed is already routine in the United States. In terms of COVID-19 vaccination, we heard much about this maybe 2 years ago, but really much less about it, I suppose, in recent months. And it's important that we, I suppose, remind ourselves of the importance of, or the place of, COVID-19 booster vaccination. And the reason for vaccinating people in pregnancy is because pregnant women are at a similar risk of COVID-19 infection as when they're not pregnant. If there are high rates in the community, that means the risk of infection is high. And there has in the past been a higher risk of severe illness in pregnancy and early in the postpartum period. That is probably less a concern with the current variants of COVID, but certainly that has been an issue in the past. And certainly in the past, there were very significant risks of pregnancy-related complications compared to non-pregnant women, including things like placentitis and stillbirth. Happily, in recent months, that has not been an issue. But nevertheless, COVID-19 vaccination remains an important intervention to offer during pregnancy, and to have that discussion and to allow the person make the most appropriate decision for themselves. Of course, making that decision involves the person balancing a number of things. Obviously, they're concerned about having sufficient immunity and protection against the particular illness, but they balance that then with the potential for complicating their pregnancy if they were not to be vaccinated and were to acquire the disease. Or indeed, if they were to be vaccinated, they worry about the potential risk this has for complicating pregnancy. So pregnancy is a complex time for decision making, and because, as my very first slide said, patients will say, well, this doesn't just affect me. And indeed, my colleague Sarah Geoghegan collaborated with a number of people, both here and in other jurisdictions, looking at the barriers and facilitators to maternal immunisation. This narrative synthesis has been published and shows a number of things that influence the uptake. So it's not just a simple recommend the vaccination and there will be routine and universal uptake. It's important to look at the things that influence this. So people's own knowledge and awareness of vaccines and diseases, people's ability to access healthcare, and all of these things kind of interplay together. People's birthplace and language proficiency, people's perception of the risks and benefits of vaccines, people's race and ethnicity impact, as does whether they have received a specific and explicit recommendation from their provider and had the opportunity to discuss with their provider the benefits and risks of vaccination or indeed of not being vaccinated. And obviously the ease with which people can access vaccination is also really important. The same research group looked at the attitudes of pregnant women towards COVID-19 vaccine, and this was just a month or so before the vaccine came on board early in 2021. And really what was identified then in this qualitative review of people's attitudes was that the safety of their unborn infant was the major driver for pregnant women when deciding whether or not to receive a COVID-19 vaccine. Certainly, the exclusion of pregnant women from vaccine trials left at-risk pregnant women facing a more complex decision than that facing non-pregnant people. And we concluded from this study that women should be supported with clear explanations from trusted healthcare professionals so that they may make an informed choice, guided and supported by an expert interpretation and provision of all the available data. Equally, Sarah Geoghegan authored this study on maternity care providers' acceptance of a future Group B strep vaccine. And this was a qualitative study carried out in Ireland, the US and the Dominican Republic. And this was interesting because she concluded that targeted educational efforts with antenatal providers should focus on highlighting safety data and potential benefits of vaccination over current strategies. And it was important, this study identified the importance of really ensuring that healthcare providers were adequately informed about all the nuances of the various illnesses that they may be recommending vaccination for, in order that they can share appropriate evidence-based information. Because certainly it has been shown previously in Ireland that healthcare provider recommendation is a powerful tool for improving vaccination uptake. The other different things that have been identified are that different providers may have different approaches to vaccine communication. Some people would identify themselves as advocates, whereas other people give the information and sort of give the patient any information they require, but don't really recommend one side or the other, which may be important, which may be the right way to do it, as long as you give very all the various aspects of information and the full complement of information. Um, Providers also in Sarah Geoghegan's study identified that there was variations in their sense of obligation to recommend vaccines. So some people felt very strongly that our role as healthcare professionals was to recommend vaccines when there was a relevant evidence base, whereas others felt it was just about giving the information. And certainly the impact of people's understanding or perception of the various risks and benefits does impact on provider recommendations as well. So I suppose we're not just looking at patients when we're talking about recommending vaccination. It's also really important that staff are educated. So that is why I suppose events like today are important, to make sure we all have the relevant and up-to-date information. Certainly it's really interesting when you look at patients' likelihood of accepting or otherwise a vaccine. So there is a sort of a continuum, and apologies the way the slide is displaying because I can't use slideshow on this. It's a little bit difficult to see all the writing, but certainly in terms of the spectrum, there are people at the left side of the screen there. I absolutely don't trust vaccines and they're not going to have any vaccines. They refuse them all. And at the other side, there is accept all. So people who just take a vaccine regardless of information, and they're probably rare, particularly in pregnancy. Really here in the middle is where skilled communication with informed healthcare professionals can influence decisions. So this is where people are wondering whether they will take it, they have their doubts, and it's about facilitating healthcare providers to inform people appropriately in a way that the person can understand. So at the bottom of the screen, I have the link there to My Health, My Language on the HSE website. So important that we break down as many healthcare access barriers as we can, and using good information, up-to-date information, and accessible information, and having the time and resources to facilitate people to access the information in their language is really important. I work in the Dove Clinic in the Rotunda Hospital. So this is an antenatal clinic which provides antenatal care to pregnant women with infectious diseases and also pregnant women with addiction. And in that clinic, over the past number of years, we have run, in collaboration with our colleagues in Safety Net Inclusion Health, we've run vaccination clinics. And we published in the Irish Medical Journal of our experience of a few consecutive vaccination clinics. So this was in conjunction with antenatal care. People came for their antenatal care, and instead of just being recommended to have, at that point, it was flu and pertussis vaccine. So instead of just being recommended, we actually recommended and offered contemporaneously with an antenatal visit. And in this published work, we identified, we had 76 eligible women in the clinic who were eligible to either receive flu or pertussis vaccination or both. And interestingly, in the context of recommending and offering eligible women vaccination, only 12% declined one or both vaccines. The vaccine people were more likely to decline was the flu vaccine rather than pertussis, because when they had the information about the impact of pertussis infection in the neonatal period, they determined that it was appropriate for them to be vaccinated. So this just shows, if you make the vaccine accessible to people, that does improve uptake. And I think it's really important as we design and as we develop and design other areas of the health service, that we really make sure that we make vaccination accessible in the places where people are going. Particularly in pregnancy, you know, it's a short period of time, and it's important that we make it accessible. However, we did do a very good job in terms of COVID-19. Some of you may have seen some reports on the Embrace report, the UK and Ireland maternal death inquiry. And while 14% of maternal deaths, so these were deaths during pregnancy or up to 6 weeks after childbirth, were related to COVID-19 in the last triennium. There were no maternal deaths in the Republic of Ireland. And that is really, really testament to the impact of education and awareness raising around vaccination. But the maternal death inquiry also highlighted the important gaps really that can harm vaccine uptake and availability, and really what they advocated for was that pregnant women had equity in terms of participating in vaccine research and other pharmacological research, that there should be a route for rapid delivery of advice and data on new vaccines and treatment, that we need to tailor care after pregnancy to a woman's individual needs. So just because she's no longer pregnant, she may still carry some pregnancy-related risks, and certainly a number of the women who were reported as dying early in the or within this triennium died early in the postpartum period. They also recommended that staff in maternal medicine networks had the skills to care for complex physical, mental and social care needs. And indeed, they also recommended training resources to promote shared decision making and counselling on medication use. So instead of just having a blanket, this drug isn't tested in pregnancy, therefore we don't use it in pregnancy, to actually have shared decision making to afford people the opportunity to receive a particular medicine. So I hope that was helpful. In summary, vaccination in pregnancy is a really important intervention, but it's very, very important that we give people evidence-based, accessible, plain language information in whatever language or format they require it. We as healthcare providers are a trusted gateway. Research here has shown it, international research has shown it time and again, that healthcare provider recommendation.
Okay, I think that's the end of Professor Eogan's presentation. So that will also be on our website and our YouTube channel if anyone would like to watch that back. So our next presentation is from Dr. Geraldine Casey from the Health Protection Surveillance Centre, and she's going to speak about vaccine-preventable diseases in pregnancy.
Hi there, I'm Geraldine Casey. I'm a specialist in public health medicine in the HPSC. Apologies for not being present in person today at the webinar, but I've pre-recorded this and I'm going to present to you on some vaccine-preventable diseases in pregnancy. So there are many vaccine-preventable diseases that are important in pregnancy, but today I'm going to discuss measles and rubella, seasonal influenza and COVID-19, and pertussis. So rubella is obviously one of the diseases that we are concerned about people contracting in pregnancy, and is one that I think even pregnant women themselves and members of the public will be aware of. I suppose the good news is that Ireland achieved measles and rubella elimination status in 2018 and have continued to maintain elimination status. We haven't had a reported case of rubella in Ireland since 2016. And while we do not have endemic transmission of measles or rubella in Ireland, we have had measles cases in Ireland since we've achieved elimination status, mainly imported. But I suppose there are concerns around measles, and particularly around an increasing number of cases notified internationally, probably related to increased movement of people post-pandemic. We have had 4 cases of measles reported in Ireland in 2023. And we have some seroprevalence studies that indicate that we have a seronegativity among adult females of childbearing age of between 8.5 to 12.3%, as well as falling and suboptimal primary childhood immunisation uptake relating to all primary childhood immunisations, but also MMR. This image just shows a map from ECDC looking at the incidence of measles in the European region up to August 2023, and this is just to illustrate that there are areas where we have measles activity. To date this year, there have been outbreaks in Austria. There was a recent outbreak of measles in a secondary school in France, but I suppose that was at the same time as the World Cup was ongoing. So there were lots of concerns around possible transmission of that. So I suppose just to note that measles cases are occurring internationally, and there is a risk of importation of measles to Ireland. And this is a measles seroprevalence study which was conducted by the Seroepidemiology Unit in the HPSC, and it looked at the proportion of people aged 18 to 34 who had serology which was negative or positive for measles. So among this study sample, the seronegativity among females was 8.5 to 12.3%, which suggests that that is the portion of the population who is non-immune to measles. And this graph just shows the MMR uptake that we have in Ireland at 24 months. So children receive their 12-month vaccine for MMR, and we measure the proportion of children in each cohort who have received MMR vaccine, and that uptake has been suboptimal and falling and has been below 90% for the past 5 consecutive quarters. And this slide just shows the current measles notifications in Ireland between 2004 and 2023. And so we have seen a significant reduction in the number of measles notifications in Ireland, thankfully. But we have seen sporadic and imported cases occurring since we have received measles elimination status. And in 2023 to date, we have had 4 cases of measles reported. This was a family cluster, so there was 1 confirmed case and 3 other people within the household who were symptomatic. And the source was contact with somebody who had travelled from abroad and was symptomatic on returning. Luckily, there was no further spread beyond this family, but the person had attended a hospital setting. And I suppose this is particularly of note in relation to pregnant women, because measles is extremely contagious, and where we have a measles case in a healthcare setting or in any other setting, somebody who has spent any time in a room with that person, and even after that person has left the room, would be considered a close contact. And where we have people who are non-immune, and particularly say something like a pregnant woman who is non-immune, then you would consider something like immunoglobulin to reduce the risk of measles in that person. So I suppose these slides just highlight, while we can't consider MMR vaccine in pregnancy, it is important to consider the risk of measles to women who may be considering pregnancy, and so to consider ensuring that they do have their vaccinations up to date insofar as possible to prevent the risk of measles to them. Next, I'm going to talk about influenza and COVID-19. So pregnant women are at increased risk of severe and complicated influenza, including associated hospitalisation and death compared to non-pregnant women. Because of normal physiological alterations that occur with pregnancy, pregnant women can be at increased risk of more
Sorry about that, I'll try and get it back.
consider ensuring as possible to prevent the risk of measles to them. Next, I'm going to talk about influenza and COVID-19. So pregnant women are at increased risk of severe and complicated influenza, including associated hospitalisation and death compared to non-pregnant women. Because of normal physiological alterations that occur with pregnancy, pregnant women can be at increased risk of being more severely affected by conditions like influenza. And that also includes people who are postpartum, particularly in the first 2 weeks or 2 to 6 weeks postpartum. And we all know that there are significant complications that can occur in pregnancy, including pneumonia, premature labour, reduced fetal growth or low birth weight. And the risk of these is higher in the second and third trimester in pregnancy, and greater for those who have other medical conditions. So this is just some guidance that's on the HPSC website around pregnancy and the management of pregnant and postpartum women with suspected influenza. We conduct SARI surveillance, which is severe acute respiratory infection surveillance, and that occurs at the moment just in one tertiary care adult hospital in Ireland. And SARI cases are identified from new admissions through the emergency department, and includes people who are aged 15 years and older, and includes all respiratory infections that are severe and require hospitalisation. So among female SARI cases aged 15 to 49 years admitted during 2023, one of those was reported as being pregnant at the time of admission. And during the same period in 2022, 4 cases were reported as being pregnant at the time of admission. In relation to COVID-19, we know that pregnant women are at increased risk of severe COVID-19 compared to non-pregnant women, and pregnancy is associated with increased risk of admission to ICU and ventilation. This is just a report which I have linked, which is available on the HPSC website, and it looks at those pregnant and postpartum women who were admitted to intensive care with confirmed COVID-19 during the period of the 1st of March 2020 to the 31st of December 2021. So of the 63 cases that were admitted to ICU who were pregnant or less than 6 weeks postpartum between March 2020 and the 31st of December 2021, the median age of those was 32 years with an age range of 15 to 44 years. Almost half of the cases had an underlying medical condition, and the median length of stay in ICU for those who were discharged at the time of this report was 8 days, ranging from 1 to 77 days. Of those who had been discharged from ICU, 43% had received invasive ventilatory support during that time, and 24%, and a further 24% had received non-invasive ventilatory support, and no deaths were reported among this cohort. And so then, following on from this period, COVID vaccine was made available to pregnant and postpartum women. And from the 1st of September 2021 to the 31st of December 2021, 25 women were admitted to ICU who were pregnant or postpartum. 22 of these cases had not received a COVID-19 vaccine. 2 were reported as being partially vaccinated, and 1 case was reported as being fully vaccinated. In 2022, there were 390 admissions to ICU in people with COVID-19, and of those 3 were pregnant or less than 6 weeks postpartum. So that's 17% of female cases aged 15 to 44. And so far this year in 2023, there were no pregnant women or women less than 6 weeks postpartum admitted to ICU due to COVID-19. And lastly, I'm going to discuss pertussis. So pertussis notifications in Ireland between 1948 to 2018 are displayed on the slide. So the incidence of pertussis has declined following the introduction of pertussis vaccine in the 1950s. There were some concerns around pertussis vaccine safety in the mid-1970s, and that resulted in a marked decline in vaccination. So there was a subsequent increase in notifications, peaking at 3,689 notifications in 1985. So a period of low rates of disease followed until 2012, when 143 cases were reported. And at this time, there were also 2 deaths in infants reported related to pertussis. So at that time, it was recommended that pertussis vaccination be given to pregnant women. And following on from that, there was some funding made available to provide pertussis vaccination free of charge in pregnancy. And so this graph on the left shows the number of notified cases of pertussis between 2004 and 2023. So in Europe, there have been a number of countries which have reported increasing cases in pertussis. So Belgium and Denmark have reported increases in cases of pertussis, as have Spain and Croatia. And to date in Ireland in 2023, we have not seen a similar increase. So you can see that the numbers that we're seeing have reduced significantly post-pandemic, but we are heading into the winter season, and there is certainly a possibility that we will see an increase, as has been seen in Europe. So this slide then looks further at those pertussis cases notified in Ireland between 2004 and 2024, and this looks at it by age group. So as we can see, this blue line here is those who are under 6 months of age, and the majority of cases occur in those who are under 6 months of age, so who wouldn't have the benefit of being fully vaccinated against pertussis with 3 doses of 6-in-1 vaccine. Even when we saw the increase in 2012, it occurred in all the age groups, but particularly in those who are under 6 months of age. And to date, we have seen a reduction in pertussis cases among all age groups, but there has been an increase seen in Europe, and I suppose there is a risk that this could be seen in Ireland also. And finally, this graph just shows among children under 6 months of age who have been notified as having pertussis, looking at whether their mother was vaccinated during pregnancy or not. So for the vast majority of cases, women were not vaccinated during pregnancy in those infants who have had pertussis aged under 6 months. We did start to see an increase from 2017 to 2019, and we are seeing less cases now. But of all the cases that have been notified in 2022 and 2023, none of those mothers were vaccinated during pregnancy, and this is among children under 6 months who were notified as having pertussis. So it's just an opportunity to provide protection to the child by offering pertussis vaccination in pregnancy. So thank you for your time. Again, apologies that I can't be there in person. I've included some references and lots of information is available on the HPSC website and the HSE website, and I'm happy to take questions via email as needed.
Okay, many thanks to Professor Eogan and Dr. Casey for those presentations, and like I said, they will be available on our website after the webinar. Next, I might ask Cría from our office to speak a little bit about communications.
Thanks so much, Eimear. So as Eimear mentioned, I'll be discussing the communications campaign and some available resources for vaccinators. So the communications campaign for vaccines recommended in pregnancy is part of the HSE's overarching autumn and winter vaccinations campaign that launched earlier last month at the beginning of October. Next slide, please. Over the last number of weeks, we've been running advertising on different channels, so TV, radio, digital, social media, to promote winter vaccines and encourage people to keep up to date with the vaccines recommended for them. We've had key messages going out of the last couple of weeks, like top up your protection, so urging people to keep up to date with their COVID-19 vaccines and their flu vaccines, the importance of the nasal spray flu vaccine, specifically for children aged 2 to 12, the pneumococcal vaccine for people aged 65 and over, and of course, vaccines in pregnancy. So encouraging all those who are pregnant to get their flu, their COVID-19 and their whooping cough vaccines. As mentioned, these campaigns have been running on a number of different channels. And for vaccines in pregnancy specifically, we've had ads across social media, as well as radio in both English and Irish. And today, the HSE also issued a press release, so we were getting some media coverage as well for the vaccines recommended in pregnancy. Next slide, please. We've developed a campaign partner pack, which we'll share with you all following this webinar. And in that pack, you'll find sample social media tiles and messaging that we've developed, and we would encourage you to use across your own social media channels. Here you can see some examples of the assets and messaging that you can use, and we have assets and messaging both English and Irish. Next slide, please. And there you can see the Irish version as well. Next slide, please. And just before I finish up, I just wanted to highlight a couple of resources available to you. So as mentioned, we have the campaign pack that we'll share. There's also an e-learning course on vaccinations and pregnancy available on HSC Land. And we have a number of information materials on our website, immunisation.ie, for both health and care professionals, including FAQs, and for the public as well, such as leaflets and posters. Thank you very much, Eimear.
Okay, thanks very much, Cría, for that. So before we finish up, I'm going to just go through a few frequently asked questions that come to our office from healthcare professionals about vaccines in pregnancy. So the first one is about co-administration. So the Tdap vaccine can be given at the same time as the flu and COVID-19 vaccines or other inactive vaccines in pregnancy. However, it's important to note that COVID-19 vaccines should be given in a separate limb. There may be a slight increase in mild side effects when COVID-19 and flu vaccines are given at the same time. These include pain at the site of injection, headache, muscle pain, and tiredness. These side effects should only last a few days and can be relieved with paracetamol. It's important as well not to delay either the flu, the COVID-19, or the Tdap so that they can be given together. They should be given at the times that they're recommended. So another question that we will often get is, does a pregnant woman still need the whooping cough Tdap vaccine if she's recently received a tetanus-containing vaccine for a tetanus-prone wound? So the answer to this question is that yes, the Tdap vaccine is required between 16 and 36 weeks gestation, because the tetanus-containing vaccine used for tetanus-prone wounds provides no protection against pertussis infection, and also so that the vaccine can be given at the optimal time so that antibodies can be given to the baby. The Tdap vaccine can be given at any time interval after any previous tetanus-containing vaccine. The person, however, may have a local reaction to the Tdap vaccine, so it's just important to warn them about that. Regarding the seasonal influenza vaccine, we will often be asked if a woman who was pregnant at the end of the last flu season, so the 2022-2023 seasonal influenza vaccination campaign, who got the flu vaccine then and has not yet delivered her baby, should they get the 2023-2024 influenza vaccine now? And the answer to this question is that yes, NIO do recommend that a woman who was pregnant at the end of the last flu campaign, who received the flu vaccine then and has not yet delivered her baby, should get the new flu vaccine now. The reason for this is there is a new strain in this season's vaccine and immunity from the first dose could have waned. And the final FAQ that I'm going to go through is how many MMR vaccines are needed for immunity against rubella infection. So if a patient has documented evidence of having received at least one dose of a rubella-containing vaccine, irrespective of rubella serology, no further rubella vaccine is necessary. However, 2 doses may be needed for protection against measles or mumps. And finally, just to mention, as you may see it in the media regarding RSV or respiratory syncytial virus vaccinations. So RSV normally causes mild cold-like symptoms, but it can be serious, particularly in young children and older adults. Just to note that the Department of Health decides an immunisation policy in Ireland based on NIO recommendations. Currently, no policy decision has been made regarding RSV vaccines by the Department of Health. So currently there is no national RSV immunisation programme in Ireland, and however that may change. For information on RSV, please visit the hse.ie website. And finally, I just wanted to mention that regarding COVID-19 vaccines and pregnancy, the National Immunisation Advisory Committee has produced a document of questions and answers for pregnant and breastfeeding women about COVID-19 vaccination in collaboration with a few other partners. And this is available on the RCPI website. It addresses questions that women may have about COVID-19 vaccination in relation to pregnancy, breastfeeding and fertility. It answers questions such as what information is available about the safety of COVID-19 vaccines in pregnancy. So continuing evidence regarding vaccination during pregnancy has demonstrated to be safe and effective. Studies have found that COVID-19 vaccination is not associated with an increased risk of congenital malformations or birth defects, miscarriage, growth problems in the baby, preterm birth, stillbirths, or admission to the neonatal intensive care unit. A number of studies from the UK, Israel, and the United States compared pregnancy outcomes among women who received a COVID-19 vaccine in pregnancy and women who did not receive a COVID-19 vaccine in pregnancy. None reported any increased risk of adverse pregnancy outcomes in women who received a COVID-19 vaccine. Some of these studies found evidence that vaccination reduces the risk of stillbirth and preterm birth. Another question that they answer is, can a breastfeeding mother get a COVID-19 vaccine? Yes, there is no evidence that COVID-19 vaccination while breastfeeding causes any harm to breastfed children or affects the ability to be breastfed. Studies looking for vaccine mRNA in breast milk have been able to detect it or have only detected it at very low levels. If remnants of the vaccine get into breast milk, they get digested in the baby's stomach. A number of studies have shown that the protective antibodies the body makes get into breast milk at high concentrations and provide the baby with some protection against COVID-19 infection. And the last question that I'm going to go through is, will the vaccine cause infertility or reduce the chances of getting pregnant? So no studies have shown that COVID-19 vaccines do not affect fertility. Studies have shown that COVID-19 vaccination does not affect ovarian function, egg quality, fertilization, or the number of women who became pregnant. COVID-19 vaccines do not affect male fertility. 3 studies have shown that vaccination does not impact sperm quality or sperm count. Some studies have, however, found that COVID-19 infection may reduce sperm quality. And just to note, the British Fertility Society have a dedicated question and answer document on COVID-19 vaccines and fertility that was published in July 2021 and is available on their website. So just to mention some resources, you can visit hse.ie to download information leaflets, posters, videos, frequently asked questions, algorithms and administration guides about a number of vaccines. There is information for healthcare professionals available on that website as well. You can always email us at the National Immunisation with any queries that you may have. That's at immunisation@hse.ie. The immunisation guidelines for Ireland that are developed by NIO are available on the RCPI website. And it's there you'll also find the document that I mentioned, the questions and answers on COVID-19 vaccination for pregnant and breastfeeding women. Of note as well, the Royal College of Obstetrics and Gynecologist in the UK also has a frequently asked question document on COVID-19 vaccines in pregnancy and breastfeeding, which may be helpful in answering any questions that patients may have. And as always, patient information leaflets and summary of product characteristics for each vaccine is always available on the HPRA website. So thank you for attending the Q&A. I don't think we probably have time to answer any questions at the moment as we're coming up to the hour. However, if you have any questions, as I said before, please feel free to email us at the National Immunisation Office. Thank you.